Hi, well, welcome everyone. Thank you so much for joining. We're gonna let a couple more folks join us and then we'll get started for what will be a really robust conversation today. Okay, well, I'm gonna go ahead and get started while some folks still trickle in. Greetings, everyone. Thank you for joining us today for our webinar, Introducing NASTAD's Updated PrEP, PEP, and Other HIV Prevention Strategies, Billing and Coding Guide. My name is Nicole Elenov, and I am a Senior Manager on NASTAD's Prevention Team. And I'm joined by two incredible individuals today, Caroline Poiker, who is a billing and coding expert and primary author of NASTAD's Updated Guide, and Amy Killalay of Killalay Consulting, who co-led the development of the updated guide. This webinar will further walk through what's been updated in the guide and we'll share ways to best utilize the guide. The webinar is scheduled to last for 60 minutes and including time for a Q&A session. We ask that you keep your line muted and just to ensure best sound quality, and we'll be engaging in a question and answer period at the end of the webinar. We do really encourage folks to add their questions as you have them in the chat. So please utilize the chat feature throughout the conversation. And this meeting will be recorded and will be made available to you. We recognize that this webinar had a big demand and understand that not everyone might be able to join us today. So we will be recording this. And we'll also be doing a frequently asked questions that will be made available with the recording along with the slides, as we know that there may be a lot of questions today and we want to make sure they're all answered. So I would now like to turn the mic over to Maria E. Alvarez with the Centers for Disease Control and Prevention for some brief opening remarks. Over to you, Maria.
Thank you so much, Nicole. Good day, partners. My name is Maria E. Alvarez, and on behalf of CDC's Division of HIV Prevention, Program Development and Implementation branch, I am pleased to welcome you to today's webinar as the Capacity Building and Technical Assistance Lead. Thank you dearly for taking time out of your busy schedule to join us today. CDC and NASTAD really appreciate you taking time out to participate in today's webinar to review, learn, and support the release of NASTAD's PrEP, PEP, and other HIV prevention strategies billing and coding guide. Today's webinar will further walk us through the guide updates, spotlight helpful resources, and discuss strategies to best utilize the guide. Post today's webinar, health departments, local providers, and partners are encouraged to review and disseminate the billing guide widely and also to contact NASTAD's capacity building team for questions or free technical assistance services regarding the implementation of the billing guide. In addition, in HIV.gov today, and as part of CDC's quarterly HIV surveillance data tables, CDC published preliminary data on PrEP coverage. These preliminary data indicate that in 2022, for the first time, more than 1/3 of people in the US who could benefit from PrEP had been prescribed it. As we can all agree on, increasing PrEP coverage is one of the key prevention strategies outlined in the Ending the HIV Epidemic in the US initiative. For more details, please visit hiv.gov and read CDC's blog on expanding PrEP coverage in the US to achieve the EHE goals. CDC's Division of HIV Prevention remains committed to our ongoing partnerships in the provision of quality technical assistance services to support and sustain your local EHE program activities. If there are any questions for CDC, please submit them to the PS 20-2010@cdc.gov mailbox. A special thank you to Nicole, Caroline, and James, as well as the entire NASTAD PrEP TA team for their ongoing technical assistance services, leadership, and partnership to end the HIV epidemic. Thank you. Gracias. Enjoy the webinar, and back to you, Nicole and team.
Thank you, Maria. So as far as our session overview today, we'll be taking some time to set the stage and share a little bit about some of the PrEP access landscape changes, challenges, and the process when it came to developing the billing and coding guide. We'll then have Caroline talk about how to best utilize the guide. And then Amy's going to talk about implementation enforcement and the road ahead. And then we'll have some time for Q&A and discussion. And as a reminder, please feel free to add your questions to the chat at any point, and slides will be made available along with this recording. All right, so I'm going to just briefly talk about some of the PrEP access changes, challenges, and then the guide update process. So as many of you know, the PrEP landscape has had a lot of changes since the 2016 billing and coding guide that NASTAD released. And some of these changes include the introduction and implementation of the United States Preventive Services Task Force Grade A recommendation for PrEP. In 2019, there was the FDA approval of Descovy. And then in 2021, we had, in 2021, we had the approval of long-acting injectable cabotegravir, or brand name Apretude. In 2020, we had the introduction of generic PrEP, so generic TDF-FTC. And then in 2021, we had the release of CDC's updated PrEP clinical guidelines. And with these changes came a need for more billing and coding guidance, especially as patients still received bills for their PrEP services, despite the USPSTF grade A recommendation. And if I can remind folks to have their lines muted, that would be greatly appreciated. All right, great. Excuse me. Okay, so just a highlight on some of those landscape changes over the years. In addition to the changes I just mentioned, NASTAD also heard about many billing and coding challenges occurring in the field. And there were many challenges, so some of them were more in buckets. So the first bucket, we have our labs. So lab intervals. Part of the USPSTF grade A recommendation for PrEP means that labs, clinic visits, the medication all should be covered with $0 copay, so $0 cost share to the patient. And what we saw is that, for many folks' labs, maybe one of their HIV testing screenings for that year was covered, but the other screenings that are required for PrEP, the every 3 months were not being covered. So we heard that the labs were not getting covered without cost share, and the intervals were a big part of that. There was also not a way to really clearly show payers that some of these labs were for PrEP, which was another challenge that came up in conversations. For many, many years of the PrEP intervention, there was not a ICD-10 code for PrEP. There was not a right code. And so as one of our colleagues, Dr. Joseph Cheruby, calls it billing bingo. And so there was no code for PrEP, which was a big challenge to really accurately, bill for this intervention. And Caroline's going to talk a little bit about the update with the ICD-10 code for PrEP. With all of these challenges, there is the lack of capacity to manually check each claim to a health plan. So many, billing and coding folks didn't necessarily have the time to go through each claim manually to flag it as a PrEP visit or a PrEP lab. There have been a lot of health plans that have been unclear on how they will pay, unclear about ways they will accept billing. So health plans don't necessarily say how they're going to accept, a claim. So there has been a lot of inconsistent coverage, which Amy will talk about later on. Of course, there were some, billing and coding errors. So visits were being coded incorrectly. There have been stigmatizing codes, such as the high-risk homosexual behavior code. Folks would see that code on their visit papers and would, experience some stigma from that. Modifier 33 was not being adopted. That was another challenge we heard, and Caroline will talk more about Modifier 33. And then we also heard about clients having an employer plan that was grandfathered unknowingly. So these were some of the billing and coding challenges that we are working to address in the updated guide. So as far as the update process, we had over 40 individuals contribute their time and expertise, whether it was reviewing the guide, providing data resources, or sharing challenges they have and would like troubleshooted. So in January of this year, we hired Caroline. So we identified our expert billing and coding consultant, and she's amazing. We then held 2 advisory group meetings that had providers, health department personnel, so many different people. We had providers, personnel, a lot of different experts, individuals from community-based organizations, billing and coding experts. A lot of folks came and informed, our meetings. We had a conversation about oral PrEP. We had a conversation about long-acting injectable PrEP. We had conversations about post-exposure prophylaxis, which is included in this guide. And really great conversations throughout those meetings. There was also an HIV prevention advisory committee convening held through the Federal AIDS Policy Partnership, and that was in April. And we had some more discussion about some of the challenges happening in the billing and coding world for PrEP. And then throughout April and to July, we held key informant interviews. We had a request for information, and we had providers share at de-identified claims so that, we can look a little bit more about how these claims are getting, processed or rejected, so that we can work on some workarounds and appeal templates. And then lastly, we had a comprehensive guide review, both internal and externally, and that took place over the summer. And the guide was released October 5th, 2023, which was just a couple weeks ago. And it's very exciting. So here is the guide. I'm going to add a link in the chat for folks to visit it if they haven't seen it already. And we really hope that you will share this information with providers in your community, so that way we can have more of a streamlined billing and coding ecosystem. And with that, I'm going to pass it over to Caroline to talk more about utilizing the guide.
Thank you, Nicole. I'm going to do highlights. Obviously, the guide is very dense. The guide is long. And we did that on purpose because the more we talk to people, the more challenges came up. And we wanted to give the guidance in context. Any of you billers out there know how complicated billing can be. So I encourage you, although it's dense and although it's long, read it from beginning to end at least once, so you understand the context. There's new and exciting. Billing and coding is all I've ever done. And exciting coding and billing updates that will really help us be successful. And I'll talk to you about a few of the highlights that are really, really very important. Okay, next slide, Nicole. So the star of the show today is not me. The star of the show today is the ICD-10 code that came out this year. It's not going to solve all of our problems, but it's absolutely going to make our lives and payers' lives a little bit easier, a lot easier, actually. We're going to talk about the HCPCS code that came out last year. We're going to talk about payer policies. I'm not going to get into individual payer policies, but as we researched and talked to everyone since January, we realized that we've been at a disadvantage since 2016 and not having published payer policies. But I'm going to mention them over and over again today because every payer has different policies or different parameters on how they want PrEP to be paid. And then we're going to talk about some highlights and some tools within this billing and coding guide that will help you be successful in either sending in clean claims so that you can get them paid the first time, or appealing and overturning denials upon appeal. So there's definitely tools that will be make us all more successful in getting these paid. So first slide, please. Next slide, Nicole. So this is what the ICD-10 code looks like when it got published. It was effective 10/1/23, Z29.81, encounter for HIV pre-exposure prophylaxis. Hooray, hurrah. Payers will know what we're sending them. We'll know what we're sending them. This is going to be great. The excludes, there's always an excludes under most ICD-10 codes. I'm including it all. This excludes, I didn't mention in the guide at all, but when you use Z29.81, it excludes Z51.6 and Z40.X. You can't use those two together. Not important in our context today. But where I have difficulty here for the ICD-10 codes, it's a wonderful thing. But in the code also notes, code also means if these other things exist at the same time as the encounter for pre-exposure prophylaxis, code them as well. So this code says, code also contact with suspected exposure to HIV virus. Code also if it exists high-risk sexual behavior. Can you click, Nicole? AHIMA wrote about this code, the American Health Information Management Association. When this code first came out, this red line isn't in the book. The code description specifically states pre-exposure, but it also says if the patient is post-exposure, you should code that too. So it's very contradictory. I think this will change over time, but for me, it's contradictory. You can't have a pre-exposure and post-exposure at the same time. So that being said, I'm going to mention payer policy. I don't believe that any payer policy will ask you to code both of those, but keep an eye out for a requirement of those two things. But that's our concern, is that they're contradictory. And the second issue, it says also code the Z72.5 series, high-risk sexual behavior. We don't in this guide recommend the use of this code because of its stigmatizing language. We talked to many providers. They've seen payers require this code if it exists. And many providers are hesitant to use it because of its stigmatizing language. I'm not telling you to do or not do anything. I'm just bringing the issues to light for those code also notes. But at any rate, the Z29.81 is the star of the show today and moving forward. It is only effective 10/1/23 and forward. It will not be effective if you go back to use it on prior claims. Okay, next slide, please. This is a HCPCS code that was effective 7/1/22 that Nicole mentioned. It's J0739. It's the long-acting injectable. What I want to call your attention to on this code, it's pretty straightforward. Getting it paid isn't always straightforward because of prior authorizations. But we're not here to talk about that. This code is for one unit. You bill J0739 with one unit. The reimbursement amount that the payer sets is for a single unit of this code. So if you're administering 600 milligrams of cabotegravir, you need to report J0739, not 600 times, but with 600 units, so that they multiply their reimbursement amount for this code by 600 and you get paid as expected. I don't think I think a lot of people know about this code. It is an update to this guide and it's very helpful. You're not using a not otherwise classified code as you were before in July of 22. So next slide, please. Okay, we're going to talk about payer policies, not specific payer policies, but what we didn't have the benefit of in 2016 was published policies by the payers telling us we will cover these services at this point and at this point, and if you report them like this. Now we do have a lot more that are out there. Payers create and publish payer medical policies, which dictates the circumstances under which certain services will get paid. These policies also define how the payer wants the provider to submit the claim. The burden of finding these payer policies may fall onto the billers and the coders in the claims resolution team. So what we didn't have in 2016 was all of these payer policies. A lot more have been published since then, which is fabulous. Please be aware they may not have updated their PrEP or the preventive services payer policies to include Z29.81 yet. Be patient with them. This isn't the only thing. This isn't the only code that they're updating. So keep an eye on them and make sure. It doesn't mean you shouldn't submit with this code. Submit with the code, get it in there, preserve your timely filing limit, get the claim in there, and then worry about how to get it paid once they update that policy. They're not going to deny the code right now. So what you need to do is find, read, understand, and adhere to the payer policies for your organization's top payers. You know your organization, isolate your top 5 payers or your top 10 payers would be fabulous. Your top 10 payers, and go out and find their payer policies on preventive service, specifically around PrEP, so that you can code and report this claim exactly how they need it to be. One of the paragraphs at the beginning of this guide, I just want to read it to you just because it sounds like a cop-out, but it's not. It's just true for billing and coding. So the ACA coverage mandate for PrEP and other preventive services is national, and it applies to all non-grandfathered plans and Medicaid expansion benefits. It applies to everyone. However, because there's not a uniform way for PrEP encounters to play out, there's also not a uniform billing and coding playbook for getting these encounters paid. So while I don't want to be a global disappointment to you all, this isn't going to be a book that says do A, B, and C and never deviate from them. Understand your payer policies, find them. If you cannot find them, communicate with the provider PrEP, your provider rep, and ask them codes, how they want these services submitted. When you talk to payers, they're going to say, I can't tell you how to code it. And while that's frustrating for billers, please understand the payer side of this, in that they're saying, I don't know what you did in that exam room, so I can't tell you how to code that service. What you're asking for specifically is their medical policy that tells you the parameters around which a PrEP claim will get paid. That's what you're going to ask for. And if it ever gets denied, what you're going to ask for is the payer policy that supports the denial. And then you'll have the information that you need. So enough about payer policies, but you need to know them. Isolate your 10 top payers and find them. I want to leave so much time for questions. Okay, next slide, please, Nicole. So what we've included in this guide is an E&M counseling decision tree, because the more providers and billers and coders that we talked about, the more different ways there were, people were coding them. So we came up with this decision tree. And you start at the leftmost circle. Was PrEP the only service that was performed at the visit? And if it's yes, you're going to drop down and you're going to code these preventive medicine counseling services, 99401 to 99404, dependent on time. These codes are by far the most commonly preferred codes by payers for PrEP counseling services. If PrEP was not the only service at the time of the encounter, was the site of service in the emergency department? If it was, you're going to code those 992, drop down to the 99281 emergency department service, but also code the preventive medicine counseling services. Because you've already said that PrEP wasn't the only thing. So if it wasn't in the emergency room, was a problem-oriented E&M performed? By problem-oriented E&M, that's coder speak for a sick visit. Was a sick visit performed and it wasn't in the emergency room, then you're going to code those office and other outpatient service codes. And then you're going to code, in addition, the PrEP counseling service as well. So you're going to code 2 E&M codes. You're going to code both the sick visit and you're going to code the E&M codes. The preventive medicine counseling codes. So if it wasn't in the emergency department, if PrEP wasn't the only thing, it wasn't in the emergency department, and it wasn't a sick visit, chances are then it was an annual exam performed. If an annual exam was performed at the time and PrEP counseling was performed, then you're only going to bill the 993 annual exam codes based on new, established, and age. But all counseling and anticipatory guidance and risk factor reduction interventions are included in these codes. So you would not code anything separate from those. So if you click down, Nicole, thank you. So modifier 25, anytime you see this and at the bottom of the screen, you're going to add a modifier 25 to one of the E&Ms that you're reporting. Remember that modifier 25 is a powerful modifier. You need to know what the rules are around that. So it's powerful. It'll get both of those things paid. And because it's so powerful, it's very well watched by everybody. So you need to understand the rules around that. I'm not going to go into those today. Next slide. Obviously, I like to talk. Sorry, everyone. Okay, so these are for PEP, not PrEP. So PEP in and of itself is a problem-oriented visit, maybe not a sick visit, but there's a problem. So if the site of service was not in the ED, you're going to use those office and other outpatient service codes, which will cover, they're wonderful because they will cover all of these sites of service, the places of service that are listed to the right. Physician office, outpatient clinic, FQHC, rape crisis center, every place, all of those will be covered under those office or other outpatient service codes. If, however, the PEP counseling happens in the ED, then you're going to use the emergency department service codes, the 99281 to 99285. So PEP is a little bit more straightforward, and you're not going to bill both of those. So there's no modifier 25 on these particular ones. I see a ton of questions and I'm being so distracted by trying to read them and answer them, but I'm not going to. I'm going to get through my slides and hope that we can get to everything. Okay, next slide, teleprep visits. Teleprep visits are telehealth services specifically for PrEP. The counseling services rendered by teleprep are the exact same that we talk in under PrEP, but they're done in a virtual environment. So along with the payer policies around PrEP, you need to go out, find, read, adhere to, and understand the payer policy around what codes they will allow for telehealth services and try to meld the two. So we talked to so many wonderful people during this process, but we talked to somebody who worked with Indiana Medicaid, I think, and I apologize if I'm getting the state wrong, but they only cover 99401. So they, when it's in a virtual environment, so they understand that that's what they can bill for telepreps. So find, understand, adhere to the payer policy around telehealth services, find out what CPT codes, what technology modifiers are required, and what place of service codes are required. Okay, there's a lot, but it's all in the guide. So next slide. So the modifiers that jump out, there's technology modifiers that are in the book that basically say which the telecommunication systems that you're using. So people will want to know, payers will want to know what kind of telecommunication you're using. But these two modifiers that I'm showing here, modifier 25 is the most powerful modifier out there for medical services. So report this visit code if it's on the same day as another visit code, like we said in the PrEP decision tree. Report this modifier with the visit code if it's performed on the same day as a minor procedure. A minor procedure in the context of PrEP could be a 96372, which is a drug administration. If you bill the visit in the drug administration without modifier 25, you're not going to get paid for both. But documentation should always clearly show significant and separately identifiable services documented and performed. We could spend an hour on modifier 25. We're not. You need to make sure all of you and your coders understand the use of it and your billers. Modifier 33, E&M is an evaluation and management code. They're the visit codes. Preventive services. Use the modifier 33 when the primary purpose of the service is the delivery of an evidence-based service in accordance with USPSTF A or B rating. Now, Nicole mentioned that it wasn't being adopted. A lot more, it's adopted well now. Don't report this service on something that's specifically identified as preventive. So you wouldn't put modifier 33 on an annual exam code. In the guide, I used an example of modifier 33 on a preventive counseling code just because I saw payer policies that required it. Do not report modifier 33 if a payer policy specifically rules out its use. So it's really important that you know your payer policies. And the last slide I have, Nicole, is the other tools that we have available for you are resources for altering claim outcome. It sounds nefarious, but it's not. They're just tools out there. If a claim was denied with no outright denied, we have commonly occurring denials out there, and the action you should take to overturn the appeal, overturn the denial, appeal, but don't take any action, regardless of what it says in the guide, until you review the payer policy and understand why they deny it. And then the claim outcome was paid, but the payment amount and the cost share deductible didn't process as expected. We've got resources in there with appeal letter templates, with rationales and supporting resources, which is all of these things existed on NASTAD, but it shows you the government and the official guidelines that are out there that are supporting your appeal, and utilize NASTAD's PrEP cost sharing complaint template that's out there. And always confirm that the plan is not a grandfathered plan before you start appealing. Understand who you're talking to. And you may need help with that. I think that's the end of my slides, and I know I just spewed a whole bunch at you, but I'm sure we'll have questions. So Nicole or Amy?
Thanks, Caroline. And we will pass it over to Amy.
Terrific. Thanks, Caroline. And we know, just to note, that folks are going to have questions. That the guide itself is dense with a lot of moving parts, and Caroline shared a lot of information. So I'm only going to go through 2 slides. And actually, Nicole, it's going to be one back. Yep. All right. So I just want to give you some sort of context on why this matters and how really just to put a little bit more detail as to the appeals resources that Caroline mentioned. So one of the main challenges that redoing and updating this billing guide was meant to address was widespread issues with folks not being able to access the full compendium of PrEP services without cost sharing. So it was not necessarily that plans have been denying all of these PrEP services en masse. It was that they have been not adjudicating them appropriately to classify them as preventative services that have to be covered without cost sharing. And to sort of go back as to why that means, or what that means and why that is that the Affordable Care Act, so sweeping federal law, requires that the vast majority of private insurance plans, that's going to include your marketplace, individual market, your small group, your self-funded plans, your fully funded plans, all of it. It is the vast majority of private insurance in this country have to cover U.S. Preventative Services Task Force grade A or B services. So USPSTF reviews any number of different preventative services, and then based on that evidence review, grades the service. Grade A or B are the highest grades a service can get. USPSTF graded PrEP, gave PrEP a grade A back in 2019. And so that meant that plans not only had to cover PrEP, but had to cover it without cost sharing. Then we get extra guidance from federal agencies in June of 2021 that say, hey, listen, we don't think plans have interpreted the coverage and cost sharing requirements appropriately, because many plans are covering the medication, the PrEP medication, without cost sharing, but aren't covering the PrEP labs and clinic visits without cost sharing. And so in June of 2021, federal agencies sent out guidance that said, PrEP includes not just a medication, but all of the CDC recommended lab services, as well as the clinic visit, as well as counseling services. So basically everything that's in the CDC guidelines for PrEP, plans have to cover without cost sharing. That helped, but as Nicole alluded to, and the challenges that were described in the creation of this guide, it still has been very problematic for providers to provide PrEP services, to bill issuers, and then to issuers to not charge cost sharing, not assume that there's a cost share charge for the PrEP client. So it's a bait and switch for the client, right? You are promising folks, and our federal law has said PrEP is free. PrEP is free. If you have insurance, PrEP is free. And then you're getting erroneous cost sharing for labs and cost sharing, or for labs and clinic visits. And then just a word, USPSTF, that came out in 2019. We now have, as Nicole mentioned, Apretude, a long-acting injectable product for PrEP. And so USPSTF is in the process of updating their recommendation. So they are still in draft form, but we could see a change to USPSTF that recognizes Apretude as part of the mix too. So now we'll go a couple more slides, and I'll end with this, and then we'll leave plenty of time for questions. So one more, and then one more again. So one thing I just want to underscore, because we've gotten, since the guide has come out, and even in the first iteration of the guide, questions around, well, how do I enforce these billing and coding guidelines that are in this billing and coding guide? And the short answer is you can't. This is a best practice guide, or a set of practices for billing and coding PrEP services appropriately. It's not a mandate. And so what's important here, though, is that I think that it can help to, first and foremost, create more uniformity across payers. Right now, you have, as Nicole said, it's throwing spaghetti at the wall and see what sticks, whack-a-mole. We've heard lots of different colorful analogies, but because there has not been a uniform way to code for PrEP services in a way that ensures they are marked as ACA preventative, have to be provided without cost sharing to the consumer, it's been very variable, and it's been difficult for providers and labs alike to really figure out, okay, this is the constellation of diagnosis codes, CPT codes, and or modifiers that are going to get the claim paid correctly and no cost sharing to the client. So number one, right, you're going to try to eliminate that variability. And number two, whenever you have an erroneous cost sharing charge, so you have a client that comes to you and they say, hey, I got hit with hundreds of dollars in my pre-deductible lab costs, but these labs were for PrEP, what gives? Then in filing your appeal, and what you have in front of you is the template that NASTAD created to help file appeals for erroneous cost sharing or claims denials. When you file that appeal, you not only use the language that references the laws and regulations, that's the basis of your appeal, but then you link to the NASTAD billing and coding guide and you say, you know, there are standards here. It shouldn't be Wild West, whatever goes, whatever payer says, you know, is how it's supposed to be. There's actually standards, and you point to the standards and you say, if a payer or the payer guidance is so wildly off the NASTAD and billing and coding guide standards, then that is indicative of something arbitrary going on, or something not in keeping and in alignment with the federal requirements that these services be covered without cost sharing. So that's another tool for you, and hopefully will reduce the variability and will help in these appeals to say, we have standards and this is so far afield from recognized standards for billing and coding. So I'm going to end there. I see lots and lots of questions, so I'll turn it to Nicole to start wading through those. Thank you.
Thank you, Amy, and thank you so much, Caroline. We have quite a few questions in the chat, but before we go into answering some of them, I want to share another reminder that this whole webinar will be including the recording, the slides, and answers to the questions that we're going to share will be added we will add them online, and we will be emailing them out to every single person that registered, as we are aware that not everyone was able to join the billing and coding webinar party. A question that was shared, and please add them to the chat. One of them that I just found is, are FQHCs using community health workers for HIV prevention? And if so, are you getting reimbursed for the service?
So I think the answer is maybe. So FQHCs, it depends if you're talking about FQHCs for Medicaid or you're talking about FQHCs for Medicare. You need to know if you're an eligible provider. I think you're more likely. Is the community health worker allowed to be enrolled in the payer in which you're billing? That's the question that you need to get answered. So if community health workers are allowed to be enrolled and they do qualify for Medicaid reimbursement in your state, then yes, I think the best place for you to get that answer is within the FQHC community in your state to find out what other people in your state or region are doing.
Thanks, Caroline. Can you talk a little bit more about modifier 25? Can the counseling code can the counseling code get paid alone outside of a regular E&M series 99212 to 99215?
So I'll answer the second one first. Yes, the counseling code can get paid all on its own. And if that's what you've done in that visit and that encounter, you're going to bill that 994 code all by itself. So when you use the modifier 25 is on that slide that had all those visit codes. If you bill two of those, if you bill two visit codes, you're going to need modifier 25 on one. Modifier 25 says, I did both of these things in this visit. I documented both of them very clearly in my notes, and I can show them to you. And I know that these two codes normally don't get paid together, but I really did do both.
Thank you.
Yep.
Mandy asks, for FQHCs, Medicare does not, oh, sorry. Okay. Does not recognize codes 99401 to 99404 as qualifying visits that correspond to the specific payment codes. Any word that this may get updated or if they have a specific code to be used?
No, Medicare hasn't finished their process yet. So they're still in the analysis stage. They just said they came out, I think it was on the 10th, and said, we told you we'd have it ready on the 10th, but we're not ready. So my guess, and it's only a guess, I understand Medicare doesn't recognize those 994 codes anywhere, anyhow. My guess is that they will come out with a specific, if they're going to cover everything like we want them to do, they're going to probably come out with a temporary G code that will cover just these PrEP visits. But I could be wrong. But as soon as it's out, they'll be issuing a supplement. Yes?
Yeah.
Nicole? Okay.
Yeah. So once that comes out, we will be doing a supplement. So please stay tuned. Mark asks, I work with providers as an academic detailer. These questions frequently come up with providers. Any advice for reaching out to payers as someone that is not a clinical provider? I frequently reach a dead end with payers because I'm neither a provider or a member. And I know there was some back and forth discussion that was going on in the chat about this question, but thought, if you wanted to speak to that a little bit.
So I'll try to get, so they're trying to talk to the payers, but they're not a provider, so the payers won't talk to them. Does that sound like what the question is?
Mm-hmm.
Yeah, it's a problem. I think it is a problem because the very first thing every payer asks you is, what's your provider number? Who are you billing for? Amy, have you had any more luck when you're outside of that sweet spot? I don't know how to get them to talk to you.
No, I mean, because there's two paths, right? Like you're going in as if you're talking on behalf of a consumer, then if you have the patient on the line, that's how I've done it. So I have helped consumers who are appealing an erroneous cost sharing, for instance. And so a payer won't talk to me directly because I have no connection, but they will talk to me if I'm on the line with the beneficiary, right, the patient. And so we've been able to have conversations with plans that way, or if you sign a release. But in terms of that's kind of like you're appealing cost sharing to the patient. If you are appealing a unpaid bill from the provider, that might be a little bit different, and I have not dealt with that.
Yeah. Right. So I guess if you're calling from an organization and you're not the provider and you're not in billing, but you're calling on behalf of the organization, someone in the organization should be able to give you a provider number. If you're calling on behalf of a patient to appeal something, then have the patient on the phone that will give the payer permission to talk to you. But other than that, I don't know how you would get information or why you would do. But okay.
Clarifying question, can a preventive Z code ICD-10 diagnosis like the new PrEP code Z29.81 or code Z20.6 for suspected HIV exposure be the primary diagnosis for an office visit that is billed as an E&M CPT 99212 to 99215? Or do you have to bill that visit with both the preventive CPT and the E&M CPT?
Well, so here's that was a mouthful. I think after you see, my eyes are closed because I'm trying to concentrate. So the Z29.81 is pre-exposure prophylaxis. So that's always, in most 90% of the time, that's going to go in with the 994 code, which is the preventive counseling codes. Unless the payer specifically tells you to use one of the E&M, the 99201 to 2215. So there's the mismatch where it's pre-exposure prophylaxis. So those would normally go with the 994. And yes, it can be in the primary position. When you go to the sick visit codes for post-exposure, I get that the post-exposures of the Z20 codes are saying that you've already been exposed. And I get that the Z codes don't normally go with those. But you should have solid argument to get those paid, because you're saying the patient's been exposed. So there's a problem. It's a sick visit. It's a problem I'm addressing as a provider. I know it's counterintuitive to coders out there, but think about the words around the services, and that will give you the basis for appeal if they are denied.
Thanks. And thanks, Jason, for adding information about the upcoming rule for community health workers. Thank you. When should we absolutely use mod KX?
Oh, so modifier KX, somebody read the guide. So modifier KX is I'm looking it up right now. This is when, sorry. My computer decided to break. Go on to the next question and I'll answer that one, I promise.
I have the question for you. I have the answer for you. It's transgender.
Oh, thank you.
Yeah, it's Carmen Navedo. It's a transgender. I use that modifier all day long.
Oh, okay. So when we have, thank you very much, Carmen. So modifier KX, we've had problems with transgender, transgender men having tests that are solely for women. So you want to use the modifier KX. So you're not changing the gender of the patient on your claim form. You're informing
Here's
me.
the problem that we're having is that but the insurance, we'll have patients with transgender. They don't change their insurance. So the insurance will have them as a male and they haven't changed that whole thing. So we'll probably get a lot of denials just because of that.
Oh, okay. So when cisgender is an issue with what they're getting, the services they're getting, because the services are, most of them are the STIs that many payers will only cover for women. So you're going to use the KX modifier when you're getting inappropriate denials for a transgender man, I believe is, but Carmen is saying that, well, that's, correct. Yeah, okay, thank you. While Carmen is saying that that's all well and good, the insurance doesn't always have the same gender as the gender you're submitting. So you may get caught in kind of a catch-22, but that's, okay. Nothing like a hot seat here.
These questions, it's a three-parter. We've got best practices for teleprep visits. I understand that insurances are still in the process of making updates. Do we have an estimate of how long it will take to have these changes take place? And will the old codes be voided?
Yes, I don't know, and maybe. No. So the middle question really is, I can't tell you how long it will take payers to update them. Medicare, we're still waiting, and I really don't know when that's going to be. Payers are typically very good about updating them within 6 to 8 weeks. So I'm guessing they'll be updated in 6 to 8 weeks, and you'll be able to get all of the claims retroactively corrected if they deny in that time. Ask the first question again, Nicole. Sorry.
Yeah, no, I gave you a lot. What is the best practice for teleprep visits?
Oh, so teleprep visits, the best practice is what I said on the PrEP visits, is the 994 preventive medicine. So for teleprep visits, most likely the only thing you're doing in those visits is the teleprep itself. So the code you want to use, or the series of codes, is the preventive medicine counseling codes 99401 to 99404. And then use go to the payer and use the appropriate technology modifier, that you're using asynchronous transmission, that you're using audio only, but understand what that payer will allow from a telehealth service. So, but from a CPT code, use the 994 codes attached with the Z29.81. And then however that payer tells you to tell them that this is a telehealth service, add that on, whether it's a place of service code or whether it's a modifier.
Thank you. Can you address bill codes for patients who are treated for STIs and PrEP care at the same time?
Can I address bill codes? Bill codes. Okay, so the patient, I'm gonna guess. So the patient comes in for PrEP, but you're also screening for STIs, or you're treating for STIs. Nicole, can you tell whether it's treating or screening?
I'm just scrolling back. Treating, who are being treated for an STI.
Okay, so the patient actually has an STI, and you're going to counsel them about PrEP. So the patient comes in with the problem, which is the STI. There's not going to be a Z code attached to that. You're going to actually code that they have this, whatever the STI is, chlamydia, gonorrhea, whatever it is, and you're going to use a problem-oriented or sick visit code, the 99202 to 99215. So that everything that you do in the visit all around the STI and the treatment of the STI will be coded and go towards the E&M code, the evaluation management code, the sick visit code, whatever that is. Any counseling you do for PrEP, pre-exposure prophylaxis, you're going to use at the same visit the 99401 to 99404 codes and attach Z29.81 to that. All you want to make sure is that if a reasonable person looked at your medical record for that day, could they reasonably see your treatment for STI documentation over here and your PrEP counseling over here? All you want to do is make sure that they're distinct and separately identifiable, exactly what that modifier 25 says. So make sure that a reasonable person could see the difference. Build both of them for treatment of STIs and PrEP counseling.
Awesome. I am wondering if folks have additional questions. It seems like some of what else is in here are more comments, as well as questions about if the slides will be shared out, which they will be. Any other questions? Okay. Couple more came in. E&M 99212 to 99215 may include counseling. Is it recommended to separate out the counseling under 99401 to 99403?
Yes. In a word, yes. So if you're counseling the patient about PrEP during an otherwise sick visit, if I go in for my, not that I have any of these, for my hypertension, for my high cholesterol, say, I go in to talk to my doctor about that because I'm a person that saves all that stuff up when I'm in front of the doctor. So I go in, I do my regular visit about hypertension, high cholesterol, and then I talk to the doctor about PrEP. Those are two very different things. If he's counseling or she's counseling me about my high cholesterol and my hypertension, that's not preventive in any way. That stays with the E&M. But if I'm in there for a problem-oriented visit and I talk to the provider about that and then bring up PrEP and you spend at least 15, well, whatever the parameters are for the 99401 code are, yes, it's very reasonable and it's right to build both of those codes. As long as you've documented and performed both things, then yes.
Thank you. And I know that we are coming close to time, so we will take one more question and then we will be answering the rest and having an FAQ with the recording and the slides. If the patient has other health coverage under their employer insurance, is there a workaround, such as if the patient has coverage under managed care or Medi-Cal?
So the patient has all of those coverages? Sorry, we might have to clarify.
No, it's okay. So Emma, do you want to come off mute and ask your question?
Yes, thank you so much. Hello. So if the patient has coverage under their employer, and then they have still the managed care net, maybe still affiliated under our facility IPA, is it okay to use that particular insurance, or do we have to use the other health coverage?
So I guess you have to figure out, there's always a rule of order.
Mm-hmm.
Yeah, and Medi-Cal or any state coverage is always payer of the last resort,
Correct.
right? Right. So I guess if they have coverage under their employer insurance, you'd submit, I'm guessing, and you'll know right when I say this, you'd submit to their employer offered insurance first.
Mm-hmm.
And then if they deny because they're a grandfathered plan, right?
Mm-hmm. Mm-hmm.
Then you could submit to Medi-Cal with the denial from the first one. But
Okay.
you probably couldn't go straight to Medi-Cal or an IPA. You would probably have to, and I would guess, and I've worked with Medi-Cal, but I'm not an expert. So I would say that the employer, if I had to guess, the employer insurance would be first, and then the other insurance would be second or subsequent, and obviously Medi-Cal would always be the payer of the last resort.
Okay. And
So, but you
I'm
could
sorry.
cascade them.
Okay, because the only reason why I asked that question, because of course, if they're under the IPA, they should be responsible for that patient, correct? With all the care, even if they were affiliated under that IPA. I know that, the payer sources is the span, you have to, it is an order. The other health coverage has to be built and so forth, so forth.
Yeah.
Okay, so just
Yeah,
go that
sorry.
route. Okay, most
You know,
definitely.
yeah. And
Okay.
thanks, Emma.
Thank you.
So we'll definitely go through these questions, and we may, because we have contact information, we may try to clarify just so we have whole, a really whole, um, solid question and answer period. And I know there were a lot of people who couldn't get on the call, right, Nicole? Do they have an avenue for asking?
We will create that avenue so that they can ask those questions.
Perfect.
And Jill, to answer your question, we will be taking all of the questions that we talked about today. We'll be writing those down, and that way we'll have answers to those as well. So we will have an FAQ released with the other resources.
Okay.
So just want to say a big thanks to you all for taking time to come to this webinar today. We will be working on getting the slides, recording, and FAQ out to you all in the next week or so. And this will be going out to all of the folks that registered. We've added the billing guide to the chat, as well as the links for the PrEP cost sharing complaint template. I'm going to add those back in the chat before people log off. And just want to say again, thank you so much for coming today. Thank you to Caroline and to Amy for their presentations. And thank you again to all of you for wanting to be, as great of stewards as possible and making sure folks get PrEP without having to pay any money out of pocket. So I hope you all have a good rest of your day. Thanks again, and cheers. Have a good one. Thank you.